Okay. Let me give you a little lay of the land here. We have 2 more sessions. This session is going to start a little late, as you may have noticed. No problem, they get there full time. We have a wrap-up session at the back end of this, which we will cut by a few minutes. Don't worry, you will still have the reception at the same time. I know that must be what you're thinking about. So we've heard from we've heard from the panels, and we've heard from different levels, units of analysis, and today, right now, this moment, we're gonna think about operationalizing good ideas. And we have Debra Baetz, who is not only, is she amazing in her own right, but she's also an EMBA alum, so thank you for being an alum. She's the interim agency director for Orange County Healthcare Agency, and I want to tell you she was brought out of retirement for this job, so this is her second passion plea, so this is awesome. Thank you for your encore, and there you go.
Good afternoon, everyone. So, welcome to Operationalizing Grand Ideas, and we're going to be talking about our healthcare delivery experiences. And you're going to hear from an amazing group of panelists this afternoon. And my role is to really just introduce them and lay the groundwork, and then allow them to do the amazing things that they do, because I'm not the one you really want to hear about. This is the group that's going to share lots of great information for you. So I'm going to take a moment to introduce our entire panel, and then we'll start out with our first speaker. But first, I'd like to introduce Liz Hamel. She is the Vice President Director of Public Opinion and Survey Research with KFF, so welcome, Liz. Liz oversees the team that is responsible for the KFF Health Tracking Poll, the COVID-19 Vaccine Monitor, and ongoing survey partnerships with a variety of news organizations, such as the Washington Post, Los Angeles Times, and CNN. So please, let's welcome Liz. Next, I want to introduce Lindsey Galli, Vice President of Programs at PFCCpartners. Lindsey supports organizations, patients, and family caregivers to partner collaboratively, promoting organizational strength and improvement, and it really focuses on the importance of patient-family engagement and strategies across the country. Please welcome Lindsey. And then I'd like to introduce Dr. Veronica Kelley, Chief Mental Health and Recovery Services for the County of Orange Healthcare Agency. I'm proud to say she's a valued member of the HCA team. Dr. Kelley has over 23 years of experience as a licensed social worker in California. In her role, she is responsible for all of the behavioral health and recovery services here in Orange County. She has, prior to coming to Orange County, 13 years as in San Bernardino County, 6 of those years as the county's behavioral health director. So please welcome Dr. Veronica Kelley. Last but definitely not least is Dr. Stephen Odom, founder, CEO, Chief Clinical Officer for FT Health Families companies, such as Shift Wellness, First Responder Wellness, and the Counseling Team International. Dr. Odom is a notable healthcare specialist with over more than 30 years of experience in the field. He has been coined as the wellness expert who has published on the topic of mental health, substance use, technology. He's been presented with the National Behavioral Health Champion Award in 2018 and has also appeared on a variety of media outlets. So please welcome Dr. Stephen Odom. So in this session, our panelists will cover a variety of topics. You're going to hear about the consumer experiences, and we'll hear some data on those. We're going to talk about the importance of family caregiver engagement. We're going to talk about what all of the things we've heard about today, really how that translates at the local behavioral health department here in Orange County. And we're going to spend some time talking about the importance of caring for our first responders. And so with that, I will turn it over to Liz Hamel, our first speaker this afternoon.
Thank you, Deborah, and thanks everyone for sticking with us in the afternoon after lunch. Hopefully this will be a lively enough panel to keep everybody engaged. And so I am Liz Hamel from KFF. I left off my slide about who KFF is, but you saw some of our data earlier today. We are a nonprofit, nonpartisan health research and information organization, and we're really focused on health policy and the big healthcare issues facing the nation. I run the public opinion and survey research team at KFF, and so we do a variety of surveys of the general public, of specific populations. Really, the goal of our work is to amplify the voice of the public in health policy debates. We heard Rishi speak earlier about the people who are not in the room and often don't have a seat at the table, and that's really a lot of what we're trying to accomplish with our surveys, is to make that information about the public's views on these healthcare issues available to policymakers and other stakeholders. So, our surveys cover not just public opinion, but also people's knowledge, attitudes, and their experiences. We do also look at the role of surveys in elections and the politics of healthcare, the role of healthcare in elections and the politics of healthcare. Dean Rosen mentioned that earlier. That's actually not what I'm going to be talking about today, but I thank Dean for the shout out on that. Really today I'm going to be talking about what people are bringing to the table when they come in for healthcare experiences, sort of the big picture of patient experiences. And, normally I'm somebody who does present a lot of charts and data from specific surveys. Today, I'm actually not going to do that. I think you've seen enough data today already, but I'm going to go through some of the themes of what we've learned from our surveys over the last couple years that help inform, how we should think about the patient experience. Just to let you know, we do mostly national surveys on big picture healthcare topics. These are not surveys of patient experiences in clinical settings, but they're more surveys of the public. So you see 5 themes that I'm going to go through here, and I think pretty much every one of these is something that we've touched on earlier today, so I think we see a lot of synergies, and really I'm just kind of bringing you the public's views on these issues. So I'll start with healthcare affordability, look at people's challenges with health insurance plans, concerns about mental health, experiences with discrimination and unequal access to culturally appropriate care. And then finally, I'll close with health misinformation and declining trust in institutions and how that relates to the patient experience. So starting with healthcare affordability, we've heard a lot about this today. No matter what the context, when we ask people's biggest concerns in healthcare on our surveys, whether that's as a voting issue, whether it's your personal worries, whether it's your pocketbook concerns, it's really healthcare costs is what always tops the list for people. And you can see some data points here explaining why that is. So we find that fully half of people say that their healthcare costs are difficult to afford. This is true for many people with health insurance and people with higher incomes, but it's much, much truer for people with lower incomes and almost universal among people who are uninsured. They say it's difficult to afford the cost of healthcare. Reflecting that high cost of healthcare, we find that many people have to borrow money to pay their medical bills. So we did a survey last year where we took a broad look at medical debt. There are some studies that look specifically at people's credit records. We took a broad look saying, did you have to borrow money from family and friends? Did you put medical bills on a credit card and have to pay it off over time? And we found that a staggering 4 in 10 people say they currently have some form of debt due to medical or dental bills. In addition to that, this relates to sort of the security piece we heard earlier and the idea of what it means to be middle class. When we ask people, do you think you would be able to afford an unexpected medical bill in the amount of $500 without borrowing money? Half of people tell us no, they wouldn't be able to afford that. And this really has implications for people's mental health and well-being as well. It's really reflected in the things that people tell us that they worry about. So we just released updated survey findings on this earlier this week. When we ask the types of things that people are worried about affording, we find that unexpected medical bills and even just regular everyday healthcare expenses, we found about 3/4 of adults say they're worried about being able to afford these things, and that is higher than the share that say they're worried about being able to pay for transportation, rent, utilities, food, other necessities.
So, an important thing, and we saw some data on this from California earlier, for the clinicians in the room to keep in mind is that these costs really present a barrier sometimes to people actually going and getting the care that they need. And so we find in our national surveys that a quarter of people say that they've skipped or postponed care in the last year, specifically due to cost concerns. And this is more common among women, younger adults, people with lower incomes, and the uninsured. And then many of those people who say that they skipped care or put off care say that their health got worse as a result. So I think this is something to keep in mind, that sometimes when people are coming in for care, they've already delayed or put off care they should have gotten much earlier. So the second theme is related to the first, of course, because affordability relates to whether you have health insurance and how your health insurance plan is set up. We know that deductibles have risen a lot over the last few years, and so patients are increasingly left on the hook for high out-of-pocket costs. But looking overall at the people's experiences with their healthcare plans, just starting with the positive, most people who are insured do give their plans good ratings. They're grateful to be insured. They recognize the protection that health insurance offered. But people who are in worse health, those who have to use their plans the most, they tend to give their plans somewhat lower ratings. And another theme, as I'm sure we all recognize, health insurance can be very complicated, and many people tell us that they have difficulty understanding their plans, at least one aspect of their insurance. So this is especially true when we ask people, how easy is it for you to understand which services are covered and which you'll have to pay out of pocket? A lot of people tell us that they have trouble understanding that with their plans. And then the caveat to the overall positive ratings of health insurance plans is that when we ask people, did you encounter problems when you went to use your insurance, we find that a majority of people say, yes, they did encounter problems. Some of the most common problems that people say that they encounter include issues with claims payment, provider networks not being able to see specialists that they need to see, pre-authorization, which we heard a little bit about earlier today, and difficulty using their prescription drug coverage. We did a big survey on consumer experiences last year, and one finding that really stuck out was that people with mental health needs were particularly likely to give their health plans lower ratings and to report foregoing needed care because of cost or insurance issues. So that's a good segue into mental health, which is another topic we've heard about a lot today. This is something that, universally, almost in the US, people recognize as a problem. We did a survey where we found 9 in 10 adults said that they think there is a mental health crisis in the US today. As we heard earlier, this is a problem that is disproportionately affecting teens and young adults. Not only are we seeing more needs among that population, but we also find that younger adults are more likely to report having unmet needs for mental health care. So saying that there was a time in the past year when they thought they needed mental health services, but they were unable to get them. We've also seen across several surveys that LGBTQ plus adults also report disproportionate unmet needs for mental health care. So, like all forms of healthcare, cost is one barrier to accessing mental health services, but there are a variety of other factors that people cite as reasons for not getting mental health care they needed, and that can include lacking access to information, lacking access to providers, and cultural acceptance of using mental health care among different communities. Telehealth is another issue that was brought up earlier. The pandemic really tested our mental health care system and, in a sense, forced many services to move to virtual. And this definitely provided an access benefit for some people. But our surveys have actually found that about 40% of people say that they prefer to receive mental health services in person. So while that shift towards telehealth may be an opportunity to reach certain populations, it may also put up barriers for some patients who don't find this an acceptable option. And then finally, just one more data point on mental health. We have done some testing and surveys and found that few people are aware of the 988 crisis line that has newly become available. Just 7% of people said they'd heard a lot about this new crisis line, and 56% said they had heard nothing at all. So there's an opportunity there to make a resource like this more widely known to people who could benefit from it. So health equity has been another theme of today, and at KFF, our surveys have always focused on highlighting the experiences of underrepresented groups, and we did a big project on this last year with a survey that included an in-depth look at Black adults, Hispanic adults, Asian adults, and it actually allowed us to report on the experiences of American Indian and Alaska Native adults whose responses often can't be disaggregated from national surveys. And we did ask some questions in that survey about people's experiences with their healthcare providers. And so again, I want to start with the positive, that most people across racial and ethnic groups report having positive and respectful interactions with their healthcare providers most of the time. And that is true for majorities across groups. However, when we look at people of color, they do report these positive and respectful interactions with somewhat less frequency than their white counterparts. And this includes things like providers involving you in decision-making about your care, understanding and respecting your cultural values and beliefs, and explaining things in a way that you can understand. And in fact, perhaps more troubling, we find that 1 in 5 Black adults and 1 in 10 Hispanic, Asian, and American Indian and Alaska Native adults say that there was a time in the past 3 years where they were treated unfairly by a healthcare provider, specifically because of their race or ethnic background. And we also found in the survey that for many people of color, these experiences or concerns about having these experiences have an effect on them even before they enter a clinic or a doctor's office. So what we found was that majorities of Black, Hispanic, and American Indian, Alaska Native adults, and about 4 in 10 Asian adults say that they prepare for possible insults or they feel they need to be very careful about their appearance in order to be treated fairly when they go to a healthcare visit. This is a concept called heightened vigilance. It's well documented in other settings, but we were really struck by how common this was in terms of people's healthcare interactions. Now, some more, opportunities here. Also echoing other research, we found that Black, Hispanic, and Asian adults who say that they see more healthcare providers who share their racial and ethnic background also report having more positive and respectful interactions with providers. However, we saw a lot about the issues with diversity in the healthcare workforce. We find that most Black, Hispanic, and Asian adults say that fewer than half of their healthcare visits were with a provider who shared their race or ethnicity. So finally, the last theme I want to touch on, and this is one I don't think that has been discussed as much today, is health misinformation and trust. So health misinformation is definitely not a new problem, but it's something that really took off during the pandemic. Some of the factors that really caused this problem to get worse were some of the partisan divisions over public health measures like COVID vaccines, mandates, and masks, and also the ability of information and misinformation to spread really quickly on social media. So we've done several surveys on health misinformation, and we've tested various pieces of misinformation that we knew were circulating, things about the COVID vaccine, like the vaccine contains a microchip, about vaccines in general, that they've been proven to cause autism, several other false statements like that. And then we really wanted to find out how many people have heard these myths, and then we wanted to find out how open are people to believing these things when they hear them. So, we found that that hearing these types of misinformation is pretty widespread. But when we look at people's propensity to believe it, in our latest survey, we used a 4-point scale. We would read the false statement and say, do you think this is definitely true, probably false, or definitely false? And what we found is that for most of these statements of misinformation, there are very few people who say it's definitely true or definitely false. So very few hardcore believers or hardcore deniers. But most people fall in what we've called this muddle middle of thinking that these false claims are probably true or saying, yeah, they're probably false, but not being uncertain. And so, that really, it presents both a challenge because it means that people have trouble wading through this information, and that type of confusion can really make it difficult for people to make good choices about their health. But it also means it's an opportunity because there's an opportunity to counteract those beliefs with correct information. So I also want to touch on the trust piece, which we saw a little bit in Dean Rosen's slide earlier today, about trust in institutions in general in the US having fallen quite a bit over the last few years. And we found specifically over the course of the pandemic that trust in public health organizations had declined, and that it really had become divided by partisanship. So at the beginning of the pandemic, we found that majorities of people, Democrats, Republicans, Independents, said that they trusted the CDC and they trusted Dr. Anthony Fauci to give good information. Over the last several years, we've seen a decline in trust in those specific figures, but in public health institutions in general. And there's really been a partisan divide where that decline in trust was mostly driven by a drop in trust among Republicans. At the same time, Dean Rosen did show in his slides that overall trust in doctors has declined somewhat, but when it comes to doctors as a source of health information, trust remains very high. So we found that more than 9 in 10 people still say they trust their own doctor to make the right recommendations when it comes to health issues. So, I think this is important for the clinicians in the room in particular to keep in mind because it presents an extra challenge for you when patients come in, first of all, to know that they're being exposed to these multiple pieces of misinformation, but it also, I think, puts a higher burden on individual providers to do some of that public education when trust in the public health community is lower. So that is my themes. I'm going to pass it over to Lindsey. Thank you.
All right, hello everyone. I'd like to thank the planning partners of this conference for inviting our organization to participate in this panel with such esteemed colleagues. I feel so out of place right now, but I'm really excited about this. And I feel really honored to represent the perspectives of patients and family caregivers today, and to help us all identify the why behind some of the data that we just saw. I wasn't planning on sharing this, but I felt it very fitting when I saw so much incredible data and the details and the spreadsheets and all the things that I'm unfamiliar with. When I first started engaging patients and families in improvement work, we were working on an ICU liberation project back in 2015 where, getting people off of ventilators was really important because they realized people were experiencing delirium while on ventilators. And so we met a woman who had been on a ventilator, and she joined our team. We talked to her about, what our team was looking to do. And she joined the first meeting, and we're looking at data. And we're looking at data of patients who are in the ICU who are on ventilators. And she just started crying. She was like, that's me. I'm one of those people. And there are so many other people who are on these ventilators. And then, she learned what delirium was. And it was like she found this whole new world of places that she could have an impact on based on her experience. So that's kind of my why. It's for the people who have such incredible experiences that can really contribute to improvements in healthcare. So I wanted to start off with a quote. This one is by Harriet Tubman. "Every great dream begins with a dreamer. Always remember you have within you the strength, the patience, and the passions to reach for the stars to change the world." And we've heard that word a lot today, change. It's something that I think is a theme across the board for today. And it's really change that will create a health system that is transformed. And our organization, PFCCpartners, our vision is a health system transformed and one that works with people and through communities as a partner in their well-being. So speaking of healthcare, we know that it's super complex. I've learned even how more complex it is just by listening to all of the panels today. Yeah, so really complex. Its systems are really difficult to navigate, even if you are part of the system. You know, I've heard nurses and physicians and administrators talk about how much trouble they have navigating the healthcare system when they're in it too. So imagine not being part of it and trying to figure it all out. And even more difficult to change. There's that word again. So we are PFCCpartners, or Patient and Family-Centered Care. Patient and family-centered care is the model of care that is really driving healthcare systems. We work with healthcare organizations, all types, from research to quality improvement organizations, local hospitals, health systems, for patients and family caregivers to drive improvements. We host a network, the PFA network, or Patient Family Advisor Network, that fills the space with impactful people, stories, and insights. And we do this through patient-family engagement. So patient-family engagement is the active strategy of utilizing that patient and family caregiver perspective to inform improvements. So this network is full of over 1,000 amazing people all across the country who are eager to be engaged early and often. And so through contracts and other work that we have, we engage these amazing people and their amazing experiences in that work to inform improvements across the country. And so these are people using their lived experiences to improve healthcare together in partnership with our healthcare teams, like all of you. I myself identify as a patient-family partner as well. I use my own experience being diagnosed with a blood clotting disorder to partner and hopefully improve communication practices. So I was diagnosed in 2016. I had been working at PFCCpartners for only 8 months, and my boss jokes with me saying that we don't need the actual personal experience to do this work, Lindsey, but I was like, I can't help it. So when I was diagnosed, I had blood clots in my lungs and my legs. There's the fancy words for that, but I stick with blood clots. And so I couldn't breathe. I couldn't walk from my car to my front door without taking a stop and feeling like I had to catch my breath. And so, of course, called my mom, and she took me to urgent care. And that doctor said, I don't want to scare you, but I think you might have VTE, venous thromboembolism. I worked on an improvement project that focused on VTE, so I knew a lot about it, and that scared me. I then went to the ER, where the physician there basically said, you're lucky you got here when you did, you could have died. And that scared the bejesus out of me. I could say a lot of other words there, but I won't. So, you know, maybe that physician was having a bad day. Maybe he wanted to scare me that I should have come in earlier. Or where I like to think is, what were the systems and the policies and everything in place for the communication to be that way? So, yeah, lots of opportunities, but I come to this work as a patient-family partner along with a person who has experience in engaging people in quality improvement activities. So through the PFA network, we have the honor of learning with the community of patient-family partners all across the country. So this right here is Maria. Maria is a Spanish-speaking promotora or health promoter in Los Angeles County. She is seen here talking in front of, for the first time, Department of Health Services leadership about the challenges her and her community face. We recently hosted a listening session with people who had been diagnosed with diabetes, which Maria participated in. And the amazing thing about Maria promotoras, community health workers, is they're not only representing their own personal experiences, but they have such an incredible connection to the community and are able to represent so many voices in improvement work as well. But she shared challenges with us that she had heard in her community, specifically around insurance, including the time it takes to get pre-authorization for diabetes supplies and medications, which, of course, impact their health. And so thank you, Liz, for sharing your slides earlier. So I could use some of what Liz had shared to really apply some of these patient perspectives that we've heard in our work. Our organization has the privilege of hosting a Diversity, Equity, and Inclusion Leadership Council. This is a group that I know I keep saying honored, but I'm really honored to be a part of. It's a dynamic group of Black and African American leaders in our network. We have laughed together, learned together, cried together, and experienced heartache together over the past 4 years, and it's completely changed my own perspective of the experience of Black and African American people in our country. Unfortunately, we have heard too many stories detailing instances of racism and discrimination. One member who has been a family caregiver and a patient herself has shared how she has been completely dismissed by physicians when she was caring for her mother, so going to appointments and, you know, as a family caregiver, they have the most information, and so to be dismissed by a physician doesn't feel the best. But she also shared, similar to what Liz had mentioned, so really confirming the why behind all of that data, is that they would get, both her and her mother would get dressed up and looking their best to go to their doctor appointments, even if they weren't feeling well and they were going in because they were sick, to ensure that they would get some form of respect at their appointments because they had experienced that disrespect in the past. And finally, wanted to address misinformation and trust, mostly trust, actually. So through our, we work on a hospital quality improvement contract through CMS, and lately we have been really focused on supporting hospitals through patient-family engagement, of course, to develop effective and impactful social drivers of health screening programs. So not just screening, but addressing those social drivers. I had the opportunity to interview one patient-family partner who had experienced some social inequities, and she shared the vulnerable position that she was put in when being screened for those social drivers. She shared that, you know, she was honest in front of her children about the fact that she had struggled to put food on the table for her family in the last month. So what really got her was that she was honest, but the hospital didn't have resources to support her needs. And that really broke her trust. And she simply stated, you know, don't ask me the questions if you're not going to help me. And so what we have really focused on, because yes, definitely that one-on-one, you know, clinician-patient relationship and the trust that comes with it is vital. But we really want to focus on building a trustworthy organization. And so in a we did a knowledge cafe at the Camden Coalition Conference last November, I believe it was. And the theme of the Knowledge Cafe was to gather information around what successful, impactful, and effective social drivers of health screening programs look like. And one of those points was building a trustworthy organization. We were like, great, but what does that look like? And so this is what participants shared with us, and these participants were all over the board. You know, we had health system leadership, administration, of course, patient family partners. We had community health workers there, research, quality improvement, you name it, they were in the room. And these are some of the things that we shared. And I think I'll let you guys kind of read through it, but the one that always sticks out to me is representation matters. And I think we saw some of the data from earlier that it really does matter, and there is so much opportunity to ensure that, you know, those who are screening for social drivers, or, you know, those who are caring for patients, it matters when they are representative of that patient and, you know, their family and their culture. So I just wanted to call that one out, and that's kind of where I will wrap up. I didn't include a slide with my information, but happy to chat afterwards and share my information if you'd like to learn more. But thank you so much.
So hi, everyone. I'm Veronica Kelley. The only one who calls me Veronica is my mom, and that's never good. So I was kind of thinking about our title, Operationalizing Grand Ideas, and in my head, the kind of tongue-in-cheek title I have is From Delusion to Delivery. And that's because I think whenever us in behavioral health try and right-size something into healthcare, we're told we can't do it, that people with a mental illness don't respond that way. And so I think an event like this really channels the idea that absolutely we can do all of these things, and that behavioral health, the key is health, it's all healthcare. So I would just want to go over a little bit the role of the public behavioral health system. I see we have a couple partners in here, folks who serve our population, but in California, we're special. So for Medicaid, we call it Medi-Cal, and we divide up a brain. If you have a mild or moderate mental illness, you're served by the managed care plans. If you have a severe mental illness or a serious emotional disturbance or an addiction, you're served by the specialty provider, which is the county, the behavioral health plan. And that in itself makes our system very wonky. When we look at the folks that we serve, most of the people we serve didn't start in the Medi-Cal system. They had private commercial insurance, like many of us in this room. And then their disease brought them to a place of disability where now, not only do they have a disability, but they're experiencing poverty. And then they fall into the public behavioral health system. And that's really important to call out, because I don't know that we play very well in the sandbox, the public and the private. And in Orange County, I can say we are really trying to change that. We have some of our partners here from Mind OC, where we're trying to see, can we leverage third-party payers? Can we get a payer-agnostic system where it doesn't matter who your insurance coverage is, that you just come in and you have a problem, we'll treat you? And that's a struggle. And also for the public behavioral health system, we have had equity standards. We use the old-timey term cultural competency since the early 1990s. We must address class standards, cultural and linguistic access to services. We must have staff who are representative of the people we serve. We must actually translate and interpret things. And better than that, we should have people who speak a person's language providing care. We ensure that. We're required to demonstrate it, to prove that we've done it, that when we are providing care, that we do it in a way that makes sense to the person we're providing it to. It is not one size fits all. So our system already has a lot of things going on in it. And if you ever see people who are in the public behavioral health system like myself and we look super tired, the reason I look this way is because this is an example of our current impacts, the current initiatives that we have to address. So I'm going to take them pretty quick. We have new Medi-Cal benefits, which is great, but we have to stand those benefits up with an infrastructure that hasn't been supported. So we are going live, we went live in December with a mobile crisis benefit. That's 24/7. And in Orange County, we've been doing 24/7 mobile crisis for a decade. But not in every county. And so Lake County and Modoc County, they don't do a 24/7, but now they have to. So all Medi-Cal providers, all the counties, we must have a place where you can call if you're in crisis, a psychiatric crisis. And then we have to be able to get to you with time and distance standards. We got to get to you in 30 minutes. I defy any of you to get out of here today at 5 o'clock or after you have your cocktails or whatever you guys are doing later and get your home in 30 minutes. We have to do that. We don't have lights and sirens. We just have to get there and provide, whether that's a 5150 hold for someone who's gravely disabled, or connections to whatever it is somebody is in need of. So that's a service we just stood up, which required us in the county to add 40 new positions. Now, we've got that okay from our board of supervisors to add the positions, but now I got to get those people who will work 24/7, be certified by myself, designated to write a hold, and then roll on a hold. And they have to be able to address adults and children and substance use in any language that's presented. That's a tall lift, but we're doing that. The next one, super exciting, is 90-day jail in-reach. For those of you who are aware, I'm sure you all are, that when you go into custody, your insurance no longer is being you're not using that to bill any of the healthcare services you might receive in custody, especially Medi-Cal. This allows us to 90 days prior to release from custody, turn on your Medicaid, turn on your Medi-Cal, and we can actually get paid for the services we're providing. That is great. But we have to have the service providers who are in custody who will be able to provide those services. And we have to be able to bill those services. And that's a system that's run by the sheriff. And the sheriff doesn't usually bill Medi-Cal. So we have to all figure out, all of our counties, how we are going to do that. It's great, but it is a big lift. Peer support specialists, we've talked today about peers, and Lindsey just did. We have, in California, Senator Bell, a few years ago, really pushed for certified peers, so people with lived experience who are in recovery from a mental illness or a substance use disorder, and seeing how we can get those folks to actually also extend our services. They can connect with an individual with an illness a little bit better, perhaps, than someone who is really looking at the clinical picture only. And so peer support specialists are able to bill, and that in itself is kind of a problem because now it changes the hierarchy a little bit if I'm billing for the service I'm providing you. But counties are standing that up as well, and what we have to do is get folks who are certified, so we get peers, someone who's interested in working in this space, who's in recovery from an illness, to take a test, get certified, and then come work for us. And that's really sometimes anxiety-provoking for our folks because if they're working in our system, they might have Medi-Cal already. They know how to access our services. But now they come work for us. They're no longer going to be on Medi-Cal because they get our good county insurance. And now, when they have to see their psychiatrist, they're waiting like the rest of us. 90 days, 120 days just to get in. Another big lift for us. An exciting thing we're doing is contingency management or recovery incentives. California was the first state in the nation that's using Medicaid dollars for contingency management, which is an evidence-based practice for stimulant use disorder, where the individual who's in the program as part of their treatment, when they have a urine screen that is absent stimulants, they get a reward. And most of us understand that reward because most of us get paid to do our job as well, right? We look forward to that check. Same with this, super reinforcing. The magic number is $50, and we are rolling that out. And the exciting part is we're using public funds to do that. Community health workers or promotoras, we know that that's very, very effective. Now we want to make sure to extend, again, our treatment team that maybe those folks can bill for services. First episode psychosis, we're standing this one up as well. And it's not just for psychotic disorders, it's anyone who's having the beginnings of maybe a bipolar disorder, major depressive disorder, any of those disorders as well. We're required required to do assertive community treatment, so providing really intensive treatment for folks in the community. The county is required to do evidence-based practices, promising practices, and community-defined practices, and now the great thing we get to do is do it all to fidelity. Again, that is a big lift for us because it requires us to do very cumbersome sometimes and very expensive fidelity monitoring that we have not done in the past. It's a good thing, but there are consequences to that. Supported employment. We would love for many of our folks to go back to work if they can, and the support is going to be essential for that. We have housing enhanced case management. We want to ensure that the people that we are serving remain housed. That is essential. And then community supports that we can assist them with housing navigation. Perhaps we can give them a security deposit, help them get their documents so that they can get into housing. Those are all new Medi-Cal benefits that we are all standing up right now. We also have some quality reforms and some program reforms, payment reform. So county behavioral health is funded through sales tax and vehicle license fees. That's how we're funded. And the way we get paid is usually we get a preliminary amount of funds from we put up an amount of money for the feds, we draw down the federal portion, but we don't settle, close our books for a little bit of time. That means the money is still in limbo, if you will. It's in an account kind of earmarked for that fiscal year. And right now, we don't get paid fully, we don't settle for 6 to 10 years. So if you're thinking about business models, that ain't a business model that any of us would ascribe to, but that's the way the county system works. Luckily, we have payment reform, and now we'll be able to do an intergovernmental transfer and get money hopefully within 30 days. We'll see how that goes. But in order to do that, we had to flip all of our CPT codes. Our HCPCS all changed, and as for those of you who know billing at all, when you're billing to a code, you have to map it to, the billed service to mapping to the code, and we've had to shift all of those at the same time we're doing all of this. We have expanded when you can get services from us in the specialty side versus the managed care side for the mild and moderate. So it's sort of an open door policy. So if you happen to have a mild depression and you ended up at one of my clinics, I would do my assessment on you and get you to the right place, but I get paid to do that service. And in the past, we didn't get paid to do that service. And then you would have to retell your story over at the other office site, and this way we can just transfer your information. We are trying to integrate mental health and substance use disorder. They live in two separate sides of our house. Even though I have a clinic that is a co-occurring clinic, I have to keep 2 charts on you because I cannot intermingle the information, in particular because of 42 CFR. Our documentation is documentation that is horrendous. We have to it will take you most of the time you're doing 40% time with a client, 60% time on the chart. Real quick, just to put it in perspective, when I was in San Bernardino County, the Office of the Inspector General was reviewing this Department of Healthcare Services to see, are they doing what they're supposed to be doing in monitoring county for documentation? And what they found was, there were a few charts that they saw that had some questionable language in them. It came out to $212 million. And our county contracts say, if the feds disallow something from the state can kick it to the counties. So the counties had to pay $212 million back. We fought it a little bit and got that price down to $187. And then every county opened their books to see what happened, what did we do? And in San Bernardino County, we had one chart. In the chart, we had a clinician. The clinician was with a person who was on a 5150 hold, so a grave disability hold, waiting with the patient in an emergency department, waiting for the patient to go back into the county hospital to be on the psych unit. When they charted this, they said, at the ED, patient currently stable. Stable. Because of that stable word, that was disallowed. If the person's stable, why are they on a hold? Just that choice of word. That service, we got paid $44 for that service. 22 of that was federal dollars we drew down, and we had put up the 50%, 22. So for $44, our part of the paying back was $9 million. So words matter. So documentation reform means we're not going to look at the words like that. We're going to get you for fraud, waste, or abuse. We're not going to get you for the stylistic way that you write a chart note. We have to report everything, all of our different funding streams to the Department of Healthcare Services, and we are very complicated. We have different pots of money that the states realign to us. We have federal financial participation. We have federal grants. We have local dollars. We need to report all this up without any additional administrative funds to help us do that. We are accountable like everybody else. But the difficulty, as was stated earlier, is that most of us are looking at outputs, not outcomes. And they're very different. And how do you measure that? And we really are grappling and trying to partner better with the state so we can figure out what those things are. We have to provide full service partnerships, which mean anything sort of, for those of you who are familiar with WRAP services, whatever it takes for an individual, whether it's billable or not, we provide it. And that includes housing. And we are doing that, and that's a required thing for us. We're grappling, like many of you, with changes in minimum wage for healthcare workers. We have requirements for network adequacy, time and distance standards. How many clinicians do we have? How many do we need? And if we had 3 or 4 clinicians in a clinic who went out on maternity leave or paternity leave, I have to tell the state, because that might mean that now I'm out of network adequacy, and that's a fine. And then we're trying to address things. We have a cultural competency plan that's required every year. We're doing some reform to make it be an actually important, usable document rather than a report of how many of what we have. So on their children and youth side, I'm happy to see Children's Hospital of Orange County here. We are looking at the Children and Youth Behavioral Health Initiative, which is a multi-billion-dollar initiative that the governor has set forth a few years ago, which really allows, shifts things a little bit. And one of the most impactful, I think, is that schools now will be able to bill insurance companies for any crisis care or any clinical care that they're doing on the school site. We have a lot of shifts in infrastructure. So the governor, again, has allocated billions of dollars for us to build our system because we have all these shifts. The difficulty is we often build the plane while we're flying it. And just because we can doesn't mean we should, but we're kind of stuck in that space. So we have funds to build up infrastructure, to build locked facilities, to build mental health rehabilitation centers, to try and get folks to do boarding cares, do supportive housing in communities. We are trying to leverage all the resources that the governor is giving us. At the same time, grave disability has shifted with the recent Senate bill, which will expand the population to include people who have a substance use disorder, who may not be able to find food, clothing, or shelter, seek their own medical care, or protect their personal safety. That blows the doors off of our locked facilities, none of which take those kind of folks right now anyway. And then 988, which we already talked about, which is a centralized crisis number for everybody. We have a whole slew of benefits we're enacting now for people who are deemed incompetent to stand trial, who've committed a crime, mild or a severe crime, and they have a mental illness. And what we have to do is restore them to competency, which means help them participate in their own defense in court. And we have to do all of these different things here with very minimal funds. And then we have these new initiatives. CARE Act, which is very specific to untreated schizophrenia spectrum disorder, has nothing to do with homelessness, although it's, the idea is everyone thinks it's about homelessness. It's not. We have to work with folks to get them through a petitioning process and through a collaborative court. And then we have to figure out how we're going to start to bill commercial insurance for all the services that we are doing. Those are just the things we're doing now. Impacts that we see in Orange County, really important. Fentanyl. We have been seeing in the last few years, thankfully, a decrease in deaths related to fentanyl overdose, really important. But at the same time, we're seeing an increase in opioid use disorder. The #1 drug of choice for people going into treatment in Orange County is opioids. We're also seeing an increase in suicide rates, and unfortunately, we're seeing that increase in our youth. We are also, though, seeing an openness in people wanting to talk about behavioral health and wanting to access our services. It's just we don't have enough of those services because we don't have, another thing decreasing, we don't have the workforce. We need people to work with us. And in the public system, we work you. It's really hard, but it is the most amazing mission-driven thing you will ever do. So if anyone's looking for a job, I will be here afterward. NIMBYism, we can't do any of this if your city won't let us in. And we've struggled in Orange County, in our cities that have county clinics in them, for the cities to say, why do you need a clinic here? To serve your residents. And then finally, a thing that's really abysmal right now is California's budget. So those are just things that we are grappling with. We want to be better partners. We want to work with anyone who wants to play with us. Rishi and I were talking yesterday when we were prepping for this about how we might be able to work on some things, but if anyone is interested in getting together with County Behavioral Health, we want to play in the same sandbox. Thank you.
I think I like my job better than your job. That's a tough job right there. So hi, I'm Stephen Odom. Been a healthcare guy forever. Just a little bit of background. Early in my career, I was in lots of large not-for-profit hospital systems. On the behavioral health side, lots of lock, psych, chemical dependency, but also med-surg, everything else. Started working with special populations back in the 90s because California passed a diversion law where a lot of nurses, it turns out, were taking other people's medication, and you're not supposed to do that. But rather than putting them in prison, we would put them in treatment, and if they did well, and the BRN monitored them for 4 or 5 years, some of them could get their licenses back. Any of you guys know nurses? Yeah? Any of you love nurses? Yeah, a few things about nurses. Right? Nurses don't know how to not be nurses, ever, 24/7, 365. So you ask a nurse how she's feeling, and she says, I'm feeling fine, but you should check her blood pressure, it looks a little high. You say, stop, you're the patient. Nurses don't know how to be patients. So I kind of threw my hands up one day and said, I think we should take all the nurses and put them in a room, and whoever comes out alive is the one we'll treat. Because I also know that nurses eat their young, right? Lo and behold, a light bulb went off, and I thought, hey, maybe that's what we should do. We should treat nurses separately and alone, because then all the walls drop and they do the work they need to do. So that went really well. A couple years later, the administration came up and said, well, you did a great job with that, kiddo. Why don't you start a doctor's program? I said, that's a great idea, except for one problem, right? They're all doctors, right? So a little on the you-know-what side. Tend to like to know all the research, tend to like to have the last word. I actually did have a month and a half that was difficult because I had a neurosurgeon and a heart surgeon in treatment. At the same time, every morning over coffee, they argued as to who's more important to human life. It's like alcohol's the problem here, guys. I really liked my life. It was fun. One day I got up in the morning, my wife walked in with our 5th child, holding him under the arms. Said, you promised we'd move home to my parents after the last one was born. I said, I don't remember that conversation. And so, of course, we moved down here to Orange County. I was in the Bay Area at the time. Landed at Hoag Hospital, ran all their behavioral health, chemical dependency for about 6 years. But about 3 months in, LAPD came and door knocked us. He said, would you be willing to treat officers? I said, I'd love to do that. The problem was they were sending us one at a time. And so a guy or a girl would come into treatment. They'd walk out into a group, and they'd immediately say, that looks like a kid I arrested 3 times, I'm not talking. Or, no offense, but that's a Newport Beach housewife, I've got nothing in common. I'm not talking. And so I was really frustrated because I knew what I wanted to do. I finally took the leap in 2012 and said I'm going to start my own thing. Believing that public safety is a special area that we don't pay much attention to. And I read the news, and I see what everybody has to say. And I will say that the last 4 or 5 years have really changed things a lot. We've built this program. It's in Newport Beach and Huntington. It has about 75 patients in it at any given moment. They're only public safety and what we call first responders. And so that's, dispatch and every kind of law enforcement and emergency room physicians and nurses and other techs, folks like that. Every kind of fire you can imagine, local, county, state, federal. A lot of those triple letter agency folks. And they all have one thing in common, and that's that they have trauma. And they have another thing in common, and that's that they won't talk about it because they're too tough, because that's not in the job description. And as a result, all the wheels have come off their bus. They also have problems with alcohol and everything else under the sun, but it really is trauma. And so we've developed a lot of ways that we work with this population that is what I call a reactive model, right? Because we are there when you need us. Some of the things that are interesting about that is, number one, getting them to come through the door is really difficult because public safety folks and healthcare folks show up about 5 years after anybody else would, right? So even though it shouldn't be a crisis, it is. The second problem is there's so much stigma, right? There's so much stigma around mental health, especially with healthcare and public safety workers. Even though we treat it, we can't have it, right? And so what that really means is that, especially when you think about things like law enforcement, right? Every single law enforcement officer went through a full psychological evaluation to get their job, right? They had to pass it, and that was after they had background investigations that really kind of cleared the slate of most people. And so there's a real implicit message to anyone who ever becomes a cop or a firefighter, and that is, don't ever let them know there's anything wrong with you, because if you tell them, they will take away your badge and your gun. They will do a fitness for duty. And so we have a lot of walking wounded among public safety. And then you see the headlines of some bad guy doing some bad thing, and everybody wants to say, see, the cops are all bad. They're just all bad. And I don't look at it that way. I look at it kind of from a different perspective. So we'll talk about that just a little bit. I think if you look at the last 3 or 4 years, in many ways it took the lid off of the problem, because as soon as the pandemic hit, in many ways, a lot of folks in law enforcement, they didn't like the way they were being treated, they didn't like the way things were being said about them, and a lot of them just retired, right? They all know the formula, they know the math, they get out as quick as they possibly can. And so everyone left behind is now working double shifts, they're impacted, they're forced hires, they do all kinds of stuff they never did before, and the next thing you know, they're exhausted, and they're beat down, and they don't know what to do about it, and stress levels just keep going up and up and up. And nobody likes them, right? And so that's tough. Next thing you know, it's everything that we're all facing, they're all facing too, because when they come home from work, their spouses aren't happy, their kids aren't happy, nothing's good, everything's bad. Next thing you know, we start to realize that, hey, this might be deeper and more prevalent than we really think it is. And so in the public safety world, put that context into place. When everyone's pushing you and asking you what you think about things, because you all remember this too, is, when the pandemic showed up, everybody put on their masks, right? And yet public safety, especially the first responder side, everyone in EMS and all the law enforcement folks, they're out there making contact with people, not knowing what's about to happen. The other thing that happened, and you guys know this too in healthcare, is that we get really used to and ready for the things we go into work to do, right? We gear up and go do our thing. What we weren't prepared for is that when we come home, we're now bringing something home possibly too, right? And that really messed with public safety, because they can keep the world safe, but you can't let it come in my house, right? I don't know how many of you guys remember this or not, but I remember the first time I walked into my house and my wife said, sorry, you can't come in the house. You need to go to the garage, you need to take off all your clothes, and you need to put them in the washer yourself, right? That's kind of what life looked like. And so for these guys, it's that way all the time. And what that really does is it impacts stress, right? Because they're not really ready for stress like that. They're ready for the stress of a contact they make with someone in the public. Next thing you know, civil unrest is everywhere after the George Floyd death, and defund police starts up everywhere, right? And these guys are like, wait a minute, that's not me. That was that guy. And when we start to think about that, and you think about bad cops, I think what I really think of is wounded cops, right? I think about folks who passed that psychological evaluation, and now they've been doing this job for 7 years, and they keep seeing the negative, right? Some of you guys have been worked in level 1 trauma centers and places like that where, wow, the same people keep showing up again and again and again. It all looks dark, it all looks bleak, and this is the way life is. And they used to think they were optimists, and then they think they're realists, and we think they're pessimists. And that's everything's negative, everything's bad. The economy went crazy, isms start up, extremism of all kinds, and they're the ones who are supposed to be working in the middle. They're not supposed to have opinions, they're not supposed to be too far left or too far right, and yet when you have no one living in the middle anymore is when you have vacuums, and that's where you have conflict. So it's pretty negative, pretty bad for them. Next thing you know, it seems like once upon a time you could have Disaster seasons, you guys remember that? You know, we knew when fire season was coming. We knew when hurricane season was. That seems to be gone now. It seems like it's fire year, right? And it seems like it's hurricane year. Like there's hurricane warnings in California. Like what's going on here? And these are the folks who have to go, right? As soon as it happens, they're there, and they're there for extended periods of time. And then one of the strange phenomena that occurred during the pandemic was there were 0 mass casualty shootings for 4 months. Did you know that? When the mask mandates were at the highest, there was no one got killed. And as soon as the mask mandates began to go away, there were 6 or 7 shootings in about 4 weeks. So the cure was we should have all worn masks forever, right? That keeps it low. And now, you know, look what's happened over the last year and a half. It seems like every weekend there's another mass shooting, right? And so these guys and these girls have to be ready for anything and everything all the time. And yet their culture says, suck it up, buttercup. Rub some dirt on it and get back out there. If you can't handle this, you don't belong here, right? And so, yet we know that they're all getting affected by the things they see, the things that happen on a daily basis for most of them, and yet they're not supposed to do anything about it. And so then we, as the mental health world, we start to talk about them and their problems, and we call them big T's and little t's. That's really trauma, right? The problem for first responders and trauma is that they don't have trauma. Did you know that? They've just seen stuff, right? When we talk with them, they say, if you say something to them like, tell me about your first, your worst, and your most recent, you can just watch their eyes go all over the map, right? One of my first jobs in a hospital when I first was a young punk was I got to be in the ICU every time we took someone off life support. I got to be there with the family and the team, right? Sometimes I was there 10 minutes, sometimes I was there hours and hours and hours, right? I remember every detail about number 1 and number 2, and I remember number 78, because that was the last one. I cannot remember much about the ones in between, because my brain did me a favor, right? It desensitized me. And yet, at the same time, something's going on. And so we've had to redefine trauma when it comes to public safety professionals, and probably healthcare folks too. It's really just 2 types of things that bother us. The first is something called moral injury. And moral injury is what happens when I see what people do to other people, and it should never be allowed, ever. And when I do see it happen, it really makes me angry, sometimes enraged, and it also breaks my heart just a little bit. So the question isn't about quantity, it's about quality. How many of those do you need for things to really bother you? Not that many. And the second, believe it or not, is decisions. Because everyone in public safety, just like most of us in healthcare, we make decisions. And sometimes we make decisions that are the right decisions, but somebody doesn't make it as a result. And when they're out there in first responder land and it's a bad guy, they don't really care. But if it's a good person or an innocent person, that really hurts. Right? So when you see all the things that happen to kids and old people and all those kinds of folks, that's the kind of stuff that really gets to them, right? Just like it gets to healthcare folks too. Not only do they have that, but they have a life outside of their job, just like some of you have a life outside of your job, right? Your job's hard enough as it is, but then you go home, everything's supposed to be perfect, and sometimes it's not, right? Because these families are getting used to them not being around. Right? And these families get annoyed when this person comes home and wants to make decisions that we've already made decisions about. You weren't here, we had to take care of it. And so you see lots of trouble in first responder families. But then they have this culture that says, you know what, if we're going to do the things the way we want to do things, then you leave us alone when it's my time. And so what they're ultimately doing is figuring out ways to dissociate. They just don't want to think about the things they don't want to think about. And there's really adaptive ways to do it, like doing woodworking, and going for a mountain bike ride and a big run. But after a while and you're exhausted, there's a lot of easier ways to do that too. There's alcohol, there's sex, drugs, and rock and roll. Apparently there's a new addiction taking over America. It's called Amazon. You guys have heard of that one? I think it really involves collecting cardboard boxes and putting them by trash cans and hoping someone else will break them down before the trash truck comes. I think that's really what it's all about. And as a result of that, they don't really understand what's wrong. What am I supposed to be doing? And why don't we do it? This is a fire service statement. 150 years of tradition, unimpeded by progress, right? Because we've always done it this way. Why would we change? And the reason we do it a different way now is because they're dying. And no one really paid attention. Okay? And so when we look at it from that perspective, Their rate of suicide is 54% higher than the general population. The group below them are teenagers. Great, right? The other thing that we found just in 2022 is that when people are in small departments, their rate of suicide is 3 times higher, right? There's a lot of speculation about what that's about. In my mind, it has a lot to do with, you know, more people, you can't talk about much, right? When you get lost in a big department, maybe that's a little easier, but you can't do that in a little one. And these are the numbers of what we call line of duty death versus suicide. And when you see suicide numbers tracking as high or higher than line of duty death, you have a major problem on your hands. The blue side is law enforcement, the red side is fire, just to help you with your colors, right? You thought those were Republicans and Democrats, didn't you? I knew that. You notice the really high numbers of line of duty deaths on the blue side? Those are COVID deaths. Turns out law enforcement, a whole lot more folks died. And there's some speculation about that too. On the fire side, they're much more EMS oriented. They're much more used to putting on full PPE and doing things the right way. And on the law enforcement side, they also don't really require a lot of physicals, and they tend to get overweight, and they tend to have a lot of health risks, and they tend to not do things the best way because they don't have to have another physical, and they're putting your hands on people a lot, right? So that's kind of part of it. So you can see what's going on. We also know that whatever we're seeing here, it's underreported, right? Because they're really good at figuring out how to do things and not have anybody know what's happening. Okay? So all this stuff is going on, and then when we start to look at it, any law enforcement officer who makes it to 50 years old, on average, dies by 57. That's a horrible number, right? So they're not really making it, and basically it's 6 years after the day you retire. So this operationalizing a grand idea, for us it works on a couple of levels, and it kind of ties into a lot of things that were said before. One of the things is, yeah, we have services for people when they really need them at an intense level of care. But what we also do is we have another part of our organization that provides what we call employee support services. You guys probably have heard of EAP, right? But EAP is a bad word. Hi. It's okay. Come on up and share. EAP is a bad word in public safety. Most fire departments, most police departments, their employer is also a city or a county, and they have a big health plan that comes with an EAP. And that EAP doesn't necessarily have that buzzword everyone's using today, cultural competency. Because there's a special kind of cultural competency for public safety. Okay, there's way too many stories of a cop going in to see the therapist and the therapist cries. It's not a good response. We've even had folks who go in to see the counselor and then they go back the second time and the counselor fires the first responder, saying, I have to get too much supervision for you. This is bothering me. It doesn't really work. And so while we might look at that and say those providers should not be doing that, that's not what the cop thinks. That's not what the firefighter thinks. They think, well, that's a professional. They can't handle me. Maybe I'm too broken. Maybe I can't get well. And so what we do is we put together systems that do the short-term counseling, the crisis response, and the training. But the training is about normalizing their experience, to say that, of course, you're going to feel bad. Of course, you're going to be horrified. Of course, these things will bother you. And if you talk about it now, early, then by the time your career is over, it's not all locked up in your head, waiting to spill out. Because the other thing I'll say about our treatment program is that the heartbreaking moments for me is when I have a guy or a girl comes in who's now retired a year or 2 years or 5 years, and they did a great career. Everything was fine, and then when they stopped working, it got quiet. And when it gets quiet, things start to bubble up again. And so what do we need to do for them? We need to get really proactive, okay? Now here's where some of the trouble comes in. We look at it this way because we're all about health outcomes, and in public safety, we're looking at cancer now and heart disease and the suicide. But the real problem is the stress. Because you know that all those things would come down if we managed the career in a better way. So how do we start to help them mitigate that stuff? You know, one of the things in public safety is we train them absolutely and only for their sympathetic nervous system, right? Presence around the clock, rock and roll, it's time to go. But we never teach them the parasympathetic. We never teach them how to come back down again. So we try to do things like that. And we work with agencies, pretty much everybody in Southern California, most of Northern California, a lot of the Western US, and then we have big federal contracts, so we take care of the DEA, the US Forest Service, folks like that. What we have to understand with these groups is if we're going to do it that way, we have to be careful what policy says and how laws work. So for example, there was a federal law that passed called the COPS Act. And the COPS Act put something called peer support in place, that every law enforcement and fire can put in a peer support team. And the thing that they get most nervous about is, what if somebody tells me something? Can I get compelled to testify? Because that's how cops think, right? It's always going to be bad. And so this law protects them, so that's a great thing. And then state by state, we're passing laws in California and 8 other states. We have what's called a presumptive law. It's SB 542, which basically says that PTSD is a presumptive diagnosis for workers' compensation, and you only have to have 1% of your problems coming from work. The other 99% can be from your whole life. Okay? And yet, workers' compensation still delays. They still push back. They still have people go sit home for 6 months before they finally get them the help that they need. And so as we start to think about these things, while on one side, they're finally becoming willing to do things, on the other side, we still are passing laws and doing things in strange ways that don't really work out. So we need to figure out how to make the care system work better. I think we also need to think that everything you can do that's on the proactive, preventative side of this for public safety will actually change everything. The last thing I'll say is that I mentioned earlier that we're having an exodus out of public safety, especially law enforcement. Right now, 50% of people coming into law enforcement are quitting within the first 5 years. Okay, it's bad. Anecdotally, work with a lot of folks in Denver. Usually they have an open house every year. About 2,500 people show up. About 250 are interviewable, and then they can kind of pick what they want. The last 2 years now, less than 100 people have shown up, and less than 20 are hireable. Okay? And yet the people leaving public safety, leaving law enforcement, the numbers are higher than ever. So what does that mean it's going to look like in 5 years? It means that all those things we said are horrible about cops being horrible, there's not going to be any of them to pick on anymore. There's not going to be much. The last thing is, I don't know if you guys have noticed it in healthcare, but in public safety, there's a lot of complaining about the current generation coming into the workforce. I don't know if you guys have or not. Probably not, because you're probably just open and inviting. But if you think about it, this is the first time ever when we've had 4 generations in the workplace. Because you've got boomers all the way down to Zs. And that's weird because usually there's only 3. And it's you and people your parents' age and people your kids' age. And you can kind of deal with that. But what we need to realize is that the Zs are coming in with a different approach and a different attitude that may not be all bad. Okay? Fire chief I talked to last week, he said, you're not going to believe what happened. Like, I called 3 kids and offered them a job. 2 of them said they had to think about it. No one ever has to think about becoming a firefighter. The 3rd one said, I need to know a little bit more about your wellness program for me. He says, I don't know what's going on, right? Had another guy, I love my daughter, she's wonderful, she's 25. She's dating a guy that I'm a little concerned about. He's a lifeguard. He's a lifeguard, an EMT, taking his paramedic, and he's about to get hired by Long Beach Fire. It's like, oh God, here we go. And they were on a Zoom. And one of the kids on the Zoom said, you know, we heard that there's going to be bad things that happen and it's going to affect us. And I'd just like to know what the department's going to do to help us get through those things. And he said, and one of these gravelly old guys just kind of laughed. He said, that's the strangest question because if you'd asked me that 20 years ago, I would have uninvited you to join the department. But today, you asking that question, I better have a good answer, right? So we're beginning to see that public safety is changing. And in a lot of ways, you know, my mission in life at this point is I want them to get the help they need because I don't like them being vilified for having mental health problems and showing up at work anyway. Because we need what they do. They're amazing at what they do, but they also have to understand that they need to be taken care of the way everybody else does. And so I get excited every day I go to work. I love what I do. And again, I think just tying policy to everything the right way is the big challenge. Because like I told you about the peer support laws, well now Washington and Massachusetts are trying to override those peer support laws to say that, yes, if you go to a group debrief, we can compel you to testify. So it's like everything, no good deed goes unpunished, I think is what I want to say. So anyway, that's a lot, and I appreciate your time, and thanks.
I have about 10 minutes or so for some questions. So is there any questions? I see one here. So if we can get a microphone.
Thank you so much. I feel like this was a very empathetic panel, and you really gave a voice to the people that are not in the room. And I think what stood out to me was you guys sort of, you brought together a recipe, and I love the trustworthy organization, what that might look like, the culturally competent behavioral care system. And it's just so amazing that there is possibly this recipe, but we need to make this cake. And what I think I kind of know the answer from being in clinical care, now administration, of what is blocking us. But I would love to know if there was one thing, one obstacle you would love to just be taken away, what would it be? And I mean, this is a question open to all of you.
Is this on? Hello? Oh, it's funny that you mentioned cake because our organization has coined the term the funfetti approach to partnership because we imagine patients and family caregivers sprinkled into everything that we do. And, you know, a funfetti cake has different colors, different flavors, all of that. I think what we see them, and, you know, we're really pushing for patient-family engagement. We think that every health system and organization should be engaging their patients and family caregivers for improvement. But those that aren't, we find that it's, you know, it's a culture shift, and culture shift comes from the top down. So there's usually blockage by leadership who don't see the value or the benefit. You know, there was talk of ROI earlier, and it's really hard to show an ROI for patient-family engagement. You know, we have the qualitative, the stories, but some people need to see like the actual data. How did this impact this? And that's hard with PFE, but we know that it's better in the long term when patients and families are engaged, and we just need that leadership support. So that's something that I would love to see, yeah.
Say that I would want to change the bureaucracy. Bureaucracy is a classical management theory that has gone off the rails. And the focus of us building all of these levels of accountability prevent people from accessing care.
And since we're talking about behavioral health specifically, I think that we need to be more mindful of the fact that everything we do either increases stigma or decreases stigma. Everything from leadership down. So every approach has a consequence. We need to think about it.
Okay. Any other questions from the audience? That I saw.
A couple of you talked about medical and public health misinformation. I know, Liz, you talked about it from a research standpoint at Kaiser Family, but really anyone can answer this question. So we understand how severe the issue of medical misinformation has been. What best practices, either at the societal or institutional or individual clinician or first responder, we'll take that too, have you seen that has been effective? And what have you seen perhaps that hasn't worked?
I feel like we're at a place where suspicion is the norm of other, and it's kind of taken a lid off. And so what you know when someone has suspicions all the way to paranoia is that everything you say to counter that feeds the narrative. And so what we found to be most effective is never to challenge them directly, just to show them how to do things the right way and keep doing it. And that's how you bring people along and let them make their own conclusions, because you just can't tell them that they're wrong, whatever that is. It backfires every time. So, and I work with a relatively conservative crowd. Just saying.
I think there is research backing up the idea that that trying to repeat misinformation or to directly counter it may be less effective than presenting factual information. I think one of the challenges in our current media environment is that people can choose their own news sources, their sources of truth, and even the high level of trust in individual healthcare providers cuts both ways, because we know there are individual healthcare providers out there who are also furthering misinformation, sometimes for their own gain, and so I do think the best approach is really trying to communicate straight facts as opposed to trying to directly counter false information.
All right, well, let's give a round of applause for our panelists today. Thank you all.